Let's start.
Okay, sir.
Today we will discuss new topic. Also, it belongs to kidney, but it's also related to serious system. Okay, diuretics control blood pressure, also used in heart failure, also used in angina. Okay, diuretics, very important drug also for serious system. First, we classify diuretics. Number one, osmotic diuretics. Number two, carbonic anhydrase. Carbonic anhydrase inhibitors. Number three, thiazide diuretics. Number four, loop diuretics. Number five, potassium sparing. Potassium sparing diuretics. The five classes of diuretics. Okay. What are the diuretics? What they doing? Diuretics causing diuresis. What mean diuresis? Increase urine volume. Okay. So increase urine volume. So what happen inside the plasma volume? Diuretics they decrease, the plasma volume will decrease. So these diuretics are also very effective in heart failure. Diuretics effective in hypertension. Diuretics also very helpful to treat any type of edema. Okay, also very helpful in edema. Diuretics can be used in ascites. Okay, it's also a category of edema because these diuretics they doing what? They eliminate extra water. They eliminate water from body. Eliminate water from body. So they're increasing the urine volume. So what happens? Plasma volume decrease. Plasma volume decrease, venous return decrease. Venous return decrease, preload, preload will decrease. So very effective in heart failure also, hypertension also, and any other edematous condition. Okay. Some diuretics they have special uses. First we see how they're working, the different part of nephron. First we see okay, nephron, common capsule. Then we have a proximal convoluted tube. Okay. Next we have loop of Henle, which is thin descending limb. Then we have thin ascending limb, and next we have here thick ascending limb. This part is important here. Thick ascending limb, and next we have here descending. This distal part, distal tube, early distal, late distal, and this early distal, this one is the late distal. The last part is your collecting duct. It's a full nephron, okay? The different part of nephron. So how these diuretics working? They work on different part of nephron, carbonic anhydrase inhibitor, osmotic diuretic, iodide, loop diuretics, and potassium sparing diuretics. Loop diuretics. The loop diuretics. Here in this part, we having sodium, potassium, sodium, potassium, and two chloride. This is a co-transporter, okay, this part. And in this part we having sodium chloride transporter, industrial tube. The loop diuretics here, loop diuretics act here. They block this transporter, co-transporter. Sodium, one potassium, and two chloride. And thiazide diuretics, this site for action of thiazide diuretics. Okay, thiazide diuretics act on distal tube. Okay, thiazide diuretics act on distal tube. And in the last part, if you remember normal physiology, the distal tube having two category of, if you take the cross section here, the cross section, is the cross section. In the cross section, you can see the two types of cells here, two types of cells. I draw in two different colors, two category of cells here. Okay, one cell was your principal cells, another one intercalated cells, another one intercalated cells. The principal cells, what they're doing, principal cells, they absorb sodium, principal cells, they eliminate potassium. They eliminate potassium. Intercalated cells, they absorb potassium, okay, potassium absorbed, and elimination of hydrogen ion. Hydrogen is out. Potassium in here, sodium in, and potassium out. The principal cells present this distal tube here, and this one is your collecting duct. It's also your distal tube, late distal tube part. So in this area, whole area, we're having principal cells everywhere. Principal cells, principal cells, principal cells. So principal cells is a site of action of aldo. If you remember physiology, site of action of aldosterone. Okay. So this aldosterone work on principal cells. This is normal function, yeah. Work on principal cells and increase the activity of principal cells. More sodium in and more potassium going out. And the third class, potassium sparing diuretics. Potassium sparing diuretics. Potassium sparing diuretics, they act on which part of nephron? They act on principal cells. Principal cells present in distal tube also. Principal cells present in collecting duct also. Okay. So it's your third class. Loop, hazard is your potassium sparing. Okay, now come on another class here. The two classes left, one osmotic and one harmonic and hydrase inhibiting. Okay. Osmotic diuretics, 65 to 70% absorption. This will be done in proximal tube, proximal convoluted tube. Yeah. Osmotic diuretics do not have any specific type of receptor. Osmotic diuretics. These drugs they just filter and precipitate here. Osmotic diuretics they precipitate here because big part of our absorption is proximal tube. Not confused with the site of action. In sometimes they asking about what is the site of action of osmotic diuretic. Osmotic diuretics not have specific site of action. So mostly the books they write just full proximal tube. Okay, actually the real site of action is just nothing. It's not block any transporter. This drug just stay in lumen. This drug just stay in lumen, and when you put the solute, what happens? The water from the blood enter to water from the blood enter to lumen. No absorption there, okay? So osmotic diuretics working here, understand? In the lumen of proximal tubules. In the lumen of not allow the absorption of other solutes. It's very strong diuretic, this one. Osmotic diuretics, okay? Osmotic diuretics, it not allow the proximal tube for proper reabsorption. The proximal tube, another thing in proximal tube, if you remember, the proximal tube, we take out the cell of proximal tube, okay? Take out the cell of proximal tube, in proximal tube here. It's a cell of proximal tube. The proximal tube cells having brush border like this, okay? This is a proximal tube cell. The proximal tube cells, this is a lumen side, this is a basal side. The lumen side and basal side. The proximal convoluted tubules, they having carbonic anhydrase inhibitor. That's your enzyme present here. Okay, this present in proximal tubules. The carbon dioxide and water here, CO2 and H2O combine here and formation of H2CO3. H2CO3. And this acid then, this acid change to H positive and HCO3 negative. HCO3 negative. And this action done by which enzyme? Carbonic anhydrase enzyme. Which enzyme? Carbonic anhydrase enzyme. Carbonic anhydrase enzyme. Will here clear? Carbonic anhydrase enzyme. Then this hydrogen going out and sodium enter inside. Okay. Hydrogen going out and sodium enter inside. This hydrogen going out, the bicarb in the lumen, to take back that bicarb in the lumen again back to blood. This sodium, now the sodium doing counter transport with hydrogen, okay? So carbonic anhydrase inhibitor. So here, if you absorb the sodium, it's mean you also absorb the water, okay? If you absorb the sodium inside, you also absorb the water. So this side is the brush water side, yeah? Like this. So if you absorb the sodium, it's mean you also absorb the water. So absorption there. So it's mean carbonic anhydrase enzyme also help in absorption, reabsorption. The sodium and elimination of extra acid from the body. So if you block this enzyme, carbonic anhydrase inhibitor. So if you block this enzyme, no reaction here, okay? So can this hydrogen go out? No. Can this sodium come back? No. It's mean now. So water not coming back. So it's mean no reabsorption. So this drug is also act like diuretic. Understand? It's a carbonic anhydrase inhibitor act on proximal tubule. Carbonic anhydrase inhibitor is your another class. Carbonic anhydrase enzyme inhibitor. This is your osmotic diuretics. Number 1, carbonic anhydrase inhibitor. Number 2, loop diuretics. Number 3, thiazide diuretic. Number 4, potassium sparing diuretic. Number 5. Everyone clear about site of action? Any problem till now? The site of action with these diuretics. You guys clear or not? If you have anything, you can ask.
Yes, sir.
Clear, yeah? So
Yeah.
how these 5 classes are working, okay? Osmotic diuretics, must keep in mind, osmotic diuretics not have any type of specific receptor for working, okay? Osmotic, if you remember the osmotic laxative, lactulose, osmotic laxative methyl cellulose, okay? Osmotic laxative, magnesium hydroxide, magnesium citrate. The osmosis mean if you put solute on one area, for example here, there are 2 beaker here, okay? You make a solution here, you also make a solution here, okay? And now you add the solute to this side, the beaker A, this your beaker B, okay? You add more solute here, more solute here. You make a channel between them. What happens from beaker B? If you add more solute here, this solution become what? This solution become concentrated. This solution become concentrated, hypertonic solution. So from the B, free water more, water enter to A side. Understand? So this is the same action here like for osmotic diuretics. Understand? So osmotic diuretics just work in lumen, not have specific set. Why they mention they can work in full tube also, okay? They can work everywhere. The osmotic diuretic directly going in urine. Why they not mention in other part of nephron? Because the main reabsorption done by proximal. That's why osmotic diuretics were firstly filter and they act inside the proximal tube. That's why if you do not confuse with the answer here, okay? If they ask what is the site of action of osmotic diuretics, then you just click the answer proximal convoluted tube. Not mention any type of specific receptor, any type of specific enzyme, okay? Nothing, just a lumen, just a lumen of the proximal convoluted tube. Understand? Is a site of action of proximal, is a site of action of osmotic diuretics. Okay, now let's start the osmotic diuretics. First we name them. Osmotic diuretics, only one drug. Everyone know this drug, yeah. Mannitol. Mannitol, okay? It's your osmotic diuretic. Osmotic diuretics. Carbonic anhydrase inhibitor. Acetazolamide. 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 Okay. Mannitol. Acetazolamide. Mannitol. Acetazolamide. Okay. And mannitol. Acetazolamide. Mannitol is your osmotic diuretic. First, we start osmotic diuretic. What are the uses of osmotic diuretics? Diuretics. Osmotic diuretics, the name mannitol. But the most common use of osmotic diuretics. If any patient come in emergency, listen here carefully. If any patient come, this you not use like for example, one patient come to you with hypertension, one patient come to you with heart failure, one patient come to you with pulmonary edema, having high fluid in the body. Never use mannitol like this. Okay, mannitol we have because it's very strong diuretics. It's a very strong diuretic. We just give for 1 hour, then again stop. Then again give at night or afternoon like this, okay? So it's very strong diuretics. It's not used frequently. This we especially use for ICP high. If any patient having, why ICP high there? Mannitol is a life-saving drug. It's a life-saving drug for which patient? If should not decrease the ICP, this very rapidly reduce the ICP, the patient can die due to brain hernia. If the patient, for example, any patient having road traffic accident and have head trauma, having head trauma, okay? The head trauma, if the patient have the history high grade fever and now we diagnose with meningitis and patient having the fever and confusion is your encephalitis. Understand or not? Head trauma, meningitis, encephalitis. So these are the causes who can easily lead to ICP high. The patient have subarachnoid hemorrhage. The patient have brain stroke. You can see. So this mannitol is my life saving for my brain. Understand? Mannitol is life saving for my brain. It's very strong diuretics. It can reduce the take out the water. The sinus is empty. Sinuses, the dural sinuses. Very rapidly CSF absorbed. More CSF. Any condition increase the ICP. My first drug of choice must be mannitol. If any patient come to you with a history of accident and have head trauma, how you know you have ICP high? How you know you have ICP high? ICP high feature. The patient have, for example, patient have meningitis, patient have encephalitis, patient have head trauma, patient have subarachnoid hemorrhage, patient have brain stroke. This is a patient, the complaint of the patient headache, number one. Another thing, the patient having vomiting. If after trauma patient start vomiting, you must understand something wrong with brain. Okay, the headache, vomiting. This vomiting is not simple vomiting. Okay, for example, if you have some issue, some disease, you start vomiting. Before vomiting, you always have nausea. Yeah, before vomiting, you're feeling some bad thing. Yeah, oh no no no, you want to vomit. Still no vomit. You have some bad feeling. It's your nausea. It's your nausea, yeah. So always vomiting always followed by nausea, but must keep in mind in ICP high the vomiting without nausea. Just start vomiting. There's no bad feeling. Just start vomiting. Understand that vomiting. One thing, vomiting without nausea. Vomiting without nausea. Okay, vomiting without nausea. Another thing, this vomiting is very high speed vomit. This vomiting also known as projectile vomit. The what means projectile vomit? If you throw vomit content from here, vomit content go like this from the oral cavity. Vomiting not just come down like this. Oh, it's a projectile. It's mean it's vomiting with the very speed. Understand? The rapid onset of vomiting with speed is a projectile vomiting ICP high. If you further wanna confirm, you can see the pupil, you can see the papillary edema, disc edema in the retina. Okay, papillary edema, papil edema. These three signs they confirm the patient have ICP high. If the patient are having ICP high, for prophylactically, if patient have had trauma, have now the patient totally a little bit unconscious and have started vomiting and then unconscious, you must give mannitol. Understand that if the brain stroke patient gave mannitol, subarachnoid hemorrhage, the hemorrhage, any epidural hematoma, subdural hematoma, so you must give mannitol. Understand or not? So mannitol is a life saving for brain now. Understand? It's a diuretics, but it's a very effective use in ICP high cases. If the baby diagnosed with meningitis, elder person diagnosed with encephalitis caused by herpes simplex virus. So if the inflammation inside the brain, inflammation of the covering of the brain, it can lead to ICP high. Understand? So if you have ICP high, you have to use mannitol. Some very important use of mannitol in case of high intracranial pressure. High intracranial pressure. Done? Clear or not?
Yes, sir. Clear.
Okay, now the second use now. Second use now. If you remember pilocarpine we use for emergency glaucoma? Pilocarpine for emergency glaucoma, yeah, very high intraocular pressure, very high. Your angle was closed, very high intraocular pressure, and you have an option here. You have an option here. If the pilocarpine is still not, it's just a drop there. You can give IV diuretics, osmotic diuretics to reduce the pressure, intraocular pressure. In case of obstructive closer angle glaucoma, for glaucoma, okay, for acute cases of glaucoma, you can use mannitol. Understand? To reduce the intraocular pressure. The pressure due to fluid. Okay, ICP pressure due to fluid. If you remove fluid from the body, if you remove this fluid very rapidly from the body, your fluid down, your pressure down. Yeah. So you can reduce intraocular pressure. You can reduce intracranial pressure. You can reduce intraocular pressure. You can reduce intracranial pressure. Understand or not? Done? So these
Done.
two very important uses. These two uses very important uses. Okay, the must keep in mind this because the osmotic mannitol is the osmotic diuretics. Mannitol is osmotic diuretics. Yeah, so it can act on if the patient have heart failure. Listen here carefully. If the patient, we learn about the heart failure. Heart failure we can use diuretics. Yeah, heart failure we prefer diuretics. Yeah, for the after RAS blocker you can add diuretics class there, but osmotic diuretics in heart failure contraindicated, not used here. Okay, why? Because these are osmotic diuretics. They can precipitate inside the blood, because this drug just like a solute. Okay, if inside the capillary this osmotic diuretics there, what happened? The osmosis outside the water, it can precipitate the edema, it can increase the edema. heart failure lead to, if left side heart failure lead to pulmonary edema. The best drug for pulmonary edema, loop diuretics. Listen here carefully. Okay, let I explain about the loop diuretics. But here, listen here carefully. The mannitol is contraindicated in pulmonary edema. Mannitol can induce pulmonary edema. Just you imagine in the alveoli, this is a mannitol drug here in the alveoli. Okay, mannitol drug in capillary and mannitol drug around the close to alveoli. What happened? The water come out because this is a solute. Okay, this just act like a solute, just act like a solute. If this drug precipitate inside the lung, what happen inside the lung? It can aggravate the pulmonary edema. Mannitol can induce pulmonary edema, not use in pulmonary edema. Okay, it can induce pulmonary edema. Understand? The side effect of mannitol is pulmonary edema. How we can use for pulmonary edema? For pulmonary edema, we prefer thiazide or loop. Loop very best gold standard for pulmonary edema, and this we not use for pulmonary edema. Pulmonary edema contraindicate. Heart failure contraindicate. If the patient already hypovolemic, blood pressure very low, hypovolemia is a side effect. Okay, then we not use mannitol. Listen here carefully. When you're using mannitol, you must monitor BP or 10 to 20 minutes. Again, measure BP. 10 to 20 minutes again measure, because you're using menthol, you don't know what happened with BP going very low because it's very strong diuretics. Okay, it's very strong diuretics. Now we need BP measurement regularly, again and again and again and again. Okay, before giving mannitol, you must check the blood pressure. You must check the repeatedly check the blood pressure. If the mannitol is still on way, you're using mannitol in patient. Even you reduce the IOP, you reduce the ICP, you must check the blood pressure again and again and again. Okay, clear or not? Okay, so this all about mannitol. Mannitol, ICP high, IOP high, very effective drug. It's a life-saving drug in head trauma case, life-saving drug in brain stroke patient. Okay, life-saving drug in brain stroke patient, life-saving drug in any type of intracranial hemorrhage, life-saving drug in head trauma. It's a life-saving drug. Same like nitrate. Nitrate life-saving drug for MI. Yeah, life-saving drug for MI, for nitrate. So for angina, nitrate. Just here in case of brain, the life-saving drug here, mannitol. Okay, now move on. Next diuretics. Next one. Carbonic anhydrase inhibitor. Carbonic anhydrase inhibitor. Carbonic anhydrase inhibitor, the name acetazolamide. 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 Okay. Acetazolamide is a carbonic and what is the site of action of acetazolamide? Acetazolamide site of action is carbonic anhydrase enzyme. Yeah. So what is the location of carbonic anhydrase enzyme? Carbonic anhydrase enzyme present in proximal convoluted tube, or carbonic anhydrase enzyme present in red blood cell, if you remember respiratory system, for removal of CO2. For removal of CO2, we also use carbonic anhydrase enzyme. Okay, so it's present inside proximal tube, it's present inside red blood cells. In proximal tube, carbonic anhydrase inhibitor, what they're doing? In the proximal convoluted tube, I already explained the mechanism here. Now come back to nephron. Here, okay. So carbonic anhydrase inhibitor, what they're doing? They block this enzyme. Can this reaction possible? Hydrogen and this CO2 combine? No. Now, can this hydrogen, if no production, it means this hydrogen is not produced. Yeah. If this hydrogen is not produced, why you eliminate this hydrogen here? Because when you filter here, when you filter, what thing you filter here? You filter bicarb. You filter bicarb. This bicarb is going out in urine. Bicarb is going out in urine, and this bicarb is captured by this hydrogen, captured by this hydrogen. This bicarb again change to H2O, again change to CO2, and then the CO2 come back. Okay, then again formation of. So we produce extra bicarb inside and save this bicarb. Understand? to save this bicarb. If you not do this, what happen? This bicarb is going to urine. Bicarb is going to, understand or not? This bicarb is going to urine. So if this bicarb is going to urine, what happened with urine? Alkaline urine, yeah, alkaline urine, because now you not save bicarb. If you block this, okay, now focus on diuretics action here. Now for this drug have two parts. Okay, one thing disturb my pH, another thing also disturb my reabsorption for sodium. This sodium counter transport with hydrogen. So if hydrogen not going out, if hydrogen not going out, can sodium come back? Of course no. So can you reabsorb water? No. If sodium is not coming inside the cell, how water come back? Clear? So water, one thing, so carbonic anhydrase inhibitor, they causing diuresis, okay? So this drug, because we not like use for longer duration for heart failure, for MI, for hypertension, as a carbonic anhydrase inhibitor, because they have strong relation with pH. Understand? Because they have strong relation with pH, we can't use for longer duration. Okay, so if you use for longer duration for the purpose of diuresis, so it's not a good thing. Why? Because disturb your pH, easily disturb your pH. If your pH disturb, your full body disturb. It's not a game of just water. Understand? It's not just a matter of some water, some extra water. You use acetazolamide and eliminate extra water, everything well and good. No, you're going to disturb your pH. We can't use for heart failure. We can't use for pulmonary edema. We can't use for hypertension. Understand? So these diuretics have some special use. It's a diuretics, but have some special use. What are the special use of acetazolamide? Acetazolamide, what acetazolamide doing inside the body? One thing, diuresis, okay? Another thing, this base is going to urine. Understand? This base is going to urine. If this base is going to urine, you're losing something. You lose what? You're losing base. If you're losing base, now let me know what happened inside your body. What happened inside your body if you lose base? Acidosis. Because you lose base here, okay? So if you lose this base in urine, why you lose this base? Because you use carbonic anhydrase inhibitor. This base is not coming inside, yeah? So now, can you eliminate extra acid here? You also not eliminating acid, you also not take back this base back. What happened? Alkaline urine will produce alkyl because loss of base, okay? Loss of base. One thing, if you remove the base from the body, what happens inside the body? Acidosis. Acetazolamide causing what? Metabolic. Acetazolamide causing what? Metabolic acidosis. One. Okay, one concept you clear from the kidney. What happened inside the proximal tube? Inside the proximal tube. Block the carbonic anhydrase enzyme. Then the hydrogen is not going to give hand to bicarb. That's a bicarb after filtration. After filtration, this bicarb is going. Where is going? It's going to urine. Okay. How we can prevent this bicarb? We can prevent this bicarb. We use here which enzyme? Carbonic anhydrase enzyme, and we produce what? We produce proton. This proton go out and give hand to this bicarb, then this bicarb can come back. So if you block this enzyme, if you block this enzyme, can hydrogen produce? No. Understand? Can you save this bicarb? No. So this bicarb will go to urine. So what happened? Because this bicarb is coming out of blood, so you filter. Understand? So you're losing this bicarb. If you're losing this bicarb, what happens? You're losing this part. Because you lose the bicarb, yeah, you lose the base. If you lose the base, what happens inside your body? It's a metabolic acidosis. One problem. Another problem, if you remember respiratory physiology, inside the RBC, how the CO2 is going inside into the lung in the form of bicarb. This bicarb in the lungs enter to RBC or RBC. It's your RBC, okay? It's your RBC. How this bicarb is going out? Yeah, close to the cell, close to cell. What happens? CO2 combined with water. How it combined with water? Carbonic anhydrase enzyme. Okay. Then the bicarb is formed. This bicarb come out, and chloride go inside. Okay, chloride go inside, and this bicarb come out. Then this bicarb inside the lung. This happen in the tissue. This happen in tissue. Okay. So in the lungs, what happen? Again, this bicarb come inside, come back, and the hemoglobin attached with proton. Okay. So now this reaction inside the tissue. One reaction inside the tissue and one reaction inside the lungs. I make it separate here. Inside the tissue and inside the lung. This is your tissue. This RBC. When RBC arrive in lungs, we must tissue producing what? Tissue produce CO2 because they use energy. Okay, they produce ATP. The cycle there, glycolysis there. There are a lot of cycles there. Okay, so CO2. Now the CO2 enter to RBC, and inside RBC we having water. With the action of, with the help of carbonic anhydrase enzyme, we produce what? We produce H2CO3. Then this H2CO3 ionized to H positive and HCO3 negative. Understand? So this HCO3 negative come out in the fluid. Okay, understand? And the counter transport with chloride ion. This is some extra thing here. Chloride ion enter to RBC, is your RBC. So now this proton combined with hemoglobin. Now what happened inside the lungs? Inside the, when this bicarb already here in the lungs now, this bicarb go back, chloride again come out. Okay, and hemoglobin already attached with proton. This proton come from oxygen attached with hemoglobin. This proton now free, and again this bicarb come inside. They combine to form H2CO3, and then they break into H2 and plus CO2. This CO2 form again. This CO2 will expire. This CO2 will expire. If you see at cell level, what happened at the cell level? At the cell level, the cell produce, the tissue or the cell, they're producing CO2. This CO2, the first reaction, how we combine this? How we combine this? By using carbonic anhydrase enzyme. Understand? So if you using acetazolamide, can this enzyme work? Lock. Can this CO2 come to lungs directly? CO2 come to lungs directly just 20%, if you remember. Just 20%. More than 70%, 75% CO2. It's also very, very important MCQ in physiology. How CO2 arrive in lungs? In the form of 70% CO2 in the form of HCO3. Not in the form of CO2, okay? Just 20% can directly come to lungs. The remaining CO2 in the form of bicarb. So how you can form the bicarb? By using carbonic anhydrase enzyme. If you not have this enzyme, can you eliminate CO2 from body? Let me know. If you block this enzyme, can you eliminate CO2 from the body? Yes or
No.
no?
No,
So
sir.
yeah, that's a problem here. It's mean this CO2 elimination problem. Now you can see here what we done in the kidney. In the kidney, we already produce. We already lost the base. Yeah, we already lost the base. In the lungs, what we done here? CO2 retain inside the body. It can precipitate. Understand? Acetazolamide. CO2 is your acidic oxide, okay? CO2 is not going out. CO2 is not going out. Done? So CO2 is not going out. You're losing the base from the kidney. CO2 in your body. It lead to acidosis. It lead to acidosis. So that's a big problem. Why you not use acetazolamide for long term to control your blood pressure? For long term to control, for example, in case of heart, this is a diuretics, because acetazolamide has strong relation with the pH. I can't use for longer duration as I have some problem with the pH. Yeah, it lead to acidosis. So carbonic anhydrase inhibitor, they have some typical uses. What are the uses of carbonic anhydrase inhibitor? Okay, what are the uses of carbonic anhydrase inhibitor? So if you have some, you already understand what they're doing with body acidosis. Yeah, if any patient comes to you with alkalosis, can you use? If one patient come to you with alkalosis, you can use carbonic anhydrase inhibitor. What happen in alkalosis? HCO3 is very high. You can eliminate HCO3 from the kidney. Understand? You can save CO2 to increase to decrease the pH, to make the pH more acidic. So if the patient have alkalosis, so metabolic alkalosis is the use for acetazole. Understand or not? Metabolic alkalosis, you can use acetazolamide to make the pH again correct. Understand? Acetazolamide you can use for metabolic alkalosis. Okay, now if you are a mountain climber, you love for hiking, you went to hiking, yeah, you remember mountain sickness? Was some mountain sickness? It's not a motion sickness, okay? Motion sickness is something else. Nausea, vomiting while traveling, that's your motion sickness. Mountain sickness means when you went to the height at the high altitude, what happened? Oxygen pressure going down and down and down. What happened with your respiratory rate?
Faster.
High and high. If faster, what you done with CO2? You eliminate all the CO2. What happened with CO2?
Decrease.
Decrease. So at the top, now at the ground level, your pH, now your CO2 is normal, everything normal, pH was normal. When you at the top of the mountain, what happened with your pH? Now you have alkalosis. At the top of that mountain, you have alkalosis. Mountain climber, if someone have this issue after little hiking, not as much very high on the mountain, not going, just little hiking, okay, and they still have the problem like the breathing difficulty, hyperventilating, now they have motion sickness. It's known as mountain sickness. Okay, it's your mountain sickness. You travel to, doing the hiking and you're feeling, it can induce epilepsy. If you remember epilepsy cause, it can induce seizure. It can alkalosis induce seizure. Okay, alkalosis can induce seizure. Alkalosis stimulate the neuron. Acidosis depress the neuron. So this is your mountain sickness. The mountain sickness, the person having what at the top, the person having the alkalosis. Clear? Alkalosis. Now, if you remember, just now we finished RBC this mechanism. Your CO2 is going out. If you eat one tablet of acetazolamide before hiking, what happened with you? Can you eliminate CO2 very easily? No. CO2 is not going. It's good for you. Understand? Because you're going to top of the mountain, at the top of mountain oxygen pressure low, automatically increase your ventilation rate. Yeah, so if you increase your ventilation rate, respiratory rate, what happen? Your CO2 going out. If your CO2 is going out, then what happened with your pH? Alkalosis. So you can prevent this alkalosis by using acetazolamide. Understand? You can prevent this alkalosis by using acetazolamide. So we can use acetazolamide for mountain sickness. Number one, metabolic alkalosis. Second use, mountain sickness. Second use, mountain sickness. Understand or not? Second use, mountain sickness. And the third use, third use, number three, we can use for glaucoma. Oh, why for glaucoma? Aqueous humor. Aqueous humor, ciliary body also have carbonic anhydrase inhibitor enzyme. Okay, aqueous humor also need help to produce like this. Aqueous humor, ciliary body produce aqueous humor also take help from carbonic anhydrase enzyme also there. Okay, carbonic anhydrase enzyme also present in ciliary body. So if you block carbonic anhydrase enzyme, aqueous humor will low. Now you also can use acetazolamide for glaucoma. Understand? Another use, glaucoma. For glaucoma, we have big list of drugs. Yeah, for glaucoma, cholinergic agonist, pilocarpine, atropinium, physostigmine. Okay, for glaucoma. For glaucoma, beta blocker timolol. For glaucoma, beta blocker timolol. For glaucoma, this is diuretics here. Mannitol for acute emergency glaucoma, and acetazolamide also for glaucoma. Understand? Acetazolamide, these two diuretics there. Beta blocker, beta 1 blocker timolol present on beta 1 receptor present on cell body timolol, and cholinergic agonist pilocarpine. Cholinergic agonist pilocarpine you also can prefer physostigmine you also can use. Okay, understand this for glaucoma, also used for glaucoma. The three uses of acetazolamide. Metabolic alkalosis is metabolic alkalosis is not a side effect here. Okay, we can use for metabolic alkalosis. What is the side effect of acetazolamide? Side effect of acetazolamide is acidosis. Understand? What is side effect? Acidosis. Okay, side effect acidosis. The acidosis in what happen if you have acidosis more hydrogen. If more hydrogen, what happen with your potassium? More hydrogen go to cell, potassium come out. When the potassium coming out, what happen with potassium? Potassium high, hyperkalemia. Acidosis induce hyperkalemia. Understand? Acidosis induce hyperkalemia. Acidosis induce hyperkalemia. Okay, it's all about carbonic anhydrase inhibitor. Carbonic anhydrase inhibitor, the main side effect, metabolic acidosis, because carbonic anhydrase inhibitor not allow base proximal tubule to reabsorb the base. Okay, that base is going to urine. This is one problem. Another problem, it's not allow the RBC carbonic anhydrase to work properly inside the tissue. Inside the tissue, the carbonic anhydrase inhibitor, we use this enzyme to produce bicarb, yeah, HCO3 negative. Then this HCO3 negative travel to lungs and again form formation of CO2. So we need this help, carbonic anhydrase enzyme to eliminate CO2 from our body. So if you block this enzyme, no CO2 elimination, you already losing base from the kidney due to these two phenomena. What happen inside your body? Metabolic acidosis. So because this drug induce metabolic acidosis, so you can use for metabolic alkalosis patient. Okay, for metabolic alkalosis patient, we can use acetazolamide to make correct for pH, to make correction in the pH. Understand? Another very special use for hikers, for mountain climbers, if they have some more issue about the respiratory system, they having mountain sickness. What's the mountain sickness? At the when they went to the top of the mountain, what happened? Increase respiratory rate, eliminate extra CO2. When the extra CO2 is going out, what happened inside the body? Again, alkalosis. So you can prevent this extra loss of CO2, okay, by using acetazolamide. Before hiking, the hiker, the climber, they use this medication before hiking. It's very effective for them, okay? This is mountain sickness. You also can use for glaucoma. You also can use for glaucoma. Understand? These two diuretics were special. That's why they have special uses, okay? Okay, next. Third class, come back to next class. These two done, osmotic done. Carbonic anhydrase inhibitor done. Okay. Now we move on to this one. This is loop diuretics, thiazide diuretics, and last potassium sparing. Loop thiazide potassium sparing. Loop thiazide potassium sparing. Used for hypertension, used for heart failure, used for angina, used for MI. This is your real serious use, okay? The mannitol and acetazolamide we not use for heart purpose, not use for serious purpose. The mannitol osmotic diuretics we prefer for decrease ICP. My first preference decrease IOP, decrease ICP, okay, in case of head trauma, in case of subarachnoid hemorrhage, in case of brain stroke, in case of meningitis, in case of encephalitis, okay. It's all about increased ICP. So mannitol. Acetazolamide we can use to correct our pH if the patient have the issue like metabolic alkalosis and if the patient have the condition like mountain sickness. Okay, so we use carbonic anhydride inhibitor. For CVS purpose to make to reduce the plasma volume, we use loop diuretics. Now come to third class, loop diuretics. One thing keep in mind about the loop diuretics and thiazide diuretics, they both having sulfur. They both having sulfur. This sulfur is a disulfide bond because cysteine amino acid they having sulfur. Okay, just because this sulfur. This sulfur doing what? Hypersensitivity is the big problem by loop and thiazide. Keep in mind, it's a common side effect. Which side effect? Hypersensitivity. Okay, hypersensitivity common side effect of loop and thiazide. Why? Because the general group here, these both drugs also known as sulfur drugs. Sorry. Because these both drugs are sulfur drug. So sulfur drug, they having sulfur. The sulfur induce what? Hypersensitivity. Sometimes they can cause hypersensitivity type 1. Okay. So if the patient have hypersensitivity, that time we need to take precautions about loop and thiazide because they are hypersensitive. Okay. The loop diuretics, how they working? Loop diuretics. Come to nephron. Here. The loop diuretics, they block this co-transporter. One sodium, one potassium, two chloride. If you remember, 25% absorption in thick ascending limb. Yeah, 25% absorption. This is also very strong diuretics. Okay, loop diuretics we not use for blood pressure simply. Okay, for blood pressure you can use thiazide and other loop diuretics in severe pulmonary edema. Loop diuretics if you have severe volume, lot of volume load there. Okay, that time we use loop diuretics also very strong diuretics as compared to thiazide. Okay, thiazide here act on distal tube. Here absorption only 5%. So if they block 5%, it's not much stronger. Yeah, they block 25%. Which one is very stronger? Osmotic diuretics. Yeah, because they block 65%. That's why very stronger. So we not use for simply for CVS purpose. We prefer to reduce ICP. Yeah, osmotic diuretics we use to reduce ICP, not used to reduce the preload and not used to reduce the preload in case of CVS system. So thiazide diuretics and loop diuretics. Thiazide and loop diuretics. Okay. Now come to loop diuretics. What's the name of the loop diuretics? Loop diuretics. In the loop diuretics, the drug's name here, furosemide, furosemide. Okay. Tall butamide, tall butamide, butanamide, butanamide. One, okay, another, I'm writing here separately. Athacarenic, athacarenic acid. Athacarenic acid, okay. Athacarenic acid. We have sulfur here, we have sulfur here, we have sulfur here, but we not have sulfur here. Which loop diuretics not causing hypersensitivity? Oh, it's a very common question from the loop. Ethacrenic acid not cause hypersensitivity because ethacrenic acid not containing sulfur. Keep in mind, okay, it's important thing here about the loop. All loop diuretics they are hypersensitive. They can cause hypersensitivity. Exception here, ethacrenic acid. Okay, ethacrenic acid not causing hypersensitivity because not have sulfur. Understand the structure a bit different from furosemide, tolbutamide, butanamide, and ethacrenic acid. You can see the name is different. Okay, furosemide, tolbutamide, butanamide they can cause hypersensitivity, but ethacrenic acid not causing. Ethacrenic acid they're not causing hypersensitivity. Understand? So as this loop diuretics, at what time we can use this loop diuretics? Loop diuretics we use for heart failure. Loop diuretics we use for any body. If you like the patient come to you have leg edema, yeah, any edematous condition for edema, the loop diuretics we can use for ascites. Do you know ascites? Ascites due to which disease? Mostly cirrhosis. Cirrhosis, yeah, full body edema, ascites due to cirrhosis, edema, heart failure. So we can use loop diuretics. Very important to use loop diuretics. Never forget this use. Pulmonary edema. If someone asks you why you prefer loop diuretics for MI patient, MI patient, left side heart failure, pulmonary edema. Pulmonary edema very rapidly relieved by very rapidly relieved by loop diuretics. Okay, must keep in mind. Then you can give answer because loop diuretics can relieve pulmonary. That's why for MI patient, loop diuretics very best. Okay, do you remember about the morphine? Morphine we use for also use for MI patient. Yeah, for the painkiller, very strong painkiller. Why we give? Can you give nalbuphine, pethidine, mepradone, methadone, oxycodone? Okay, the other opioid. We never go for other opioid in MI patient. MI patient, why you prefer morphine? Because morphine give me two benefits. One thing, morphine stop the pain. Second thing, morphine relieve pulmonary edema. Okay, this is the reason why you use morphine for pain in MI or angina patient. Because MI or angina patient they have if the issue with the left ventricle, of course, mostly issue with the left ventricle. Morphine relieve pulmonary edema. Okay, if you combine loop diuretics also, I am adding loop diuretics also in MI patient. So now it's very good for that patient. Why patient died due to heart attack? Still heart is working. Patient died due to dyspnea. Why dyspnea? Acute pulmonary edema. All alveoli filled with fluid, so no oxygenation. Even heart still pumping after heart attack. Yeah, heart still pumping after heart attack. Patient blood pressure normal. Patient everything like oxygenation, oxygen. Some now problem with the pulmonary edema. So pulmonary edema is a main killer here for heart attack. Yeah. So if you relieve pulmonary edema, patient say patient now have for example have next life, and my patient now survive, yeah, heart still giving you output even after heart attack, your blood pressure normalize, not much low, not much high, clear, but patient still die. Why still die? Because patient still have feeling with the difficulty in breathing. Why? Because pulmonary edema. Pulmonary edema here clear, understand or not? So if you relieve pulmonary edema after heart attack, patient have more chance for survival, understand? So pulmonary edema is a key thing in pathogenesis of MI, understand? Pulmonary edema. So you relieve pulmonary edema by using which drug? Loop diuretics, morphine. Okay, morphine also help to relieve pulmonary edema. So loop diuretics we use for to relieve pulmonary edema. Relieve pulmonary edema. Other edematous condition. If any patient come to you, for example, the patient CKD patient, okay, the CLD patient, chronic liver disease patient, chronic kidney disease patient, heart failure patient, the all the patient they having edema of full body. That edema known as anasarca. For any edematous condition, you can use loop diuretics. Understand? For edematous condition, you can use loop diuretics. Understand? For heart failure, for ascites, edema, heart failure, never forget this. Okay, must keep in mind. For pulmonary edema, this is my best drug. Loop diuretics is my best drug. Okay, now come to another point. Loop diuretics. Another thing. What are the side effects here? The first side effect, hypersensitivity. Why they cause hypersensitivity? Because they are sulfur drug. Hypersensitivity. Okay, one side effect. Another side effect. Okay, so, sometimes the scenario like this: one patient was hypertensive, come to you, and you prescribe one drug for that patient. That patient also has history of heart failure. Now, after 1 month, patient come again and complain, "Hey doctor, I can't listen now. I'm deaf now." Which drug you give to that patient? You give loop diuretics. Patient was hypertensive, yeah. Patient was having a history of heart failure. So use loop diuretics. The loop diuretics are ototoxic. Loop diuretics are ototoxic. They causing deafness. They causing deafness. Understand? So deafness, hearing loss, hypersensitivity, ototoxicity, ototoxicity. Another side effect. What happened with volume? Going down. What happened with sodium? Going, everything lost. What happened with potassium? Going down. What happened with calcium? Going down. Understand? Hyponatremia, hypokalemia, hypocalcemia, hypovolemia. Hypovolemia, if water going down, what happened with blood pressure? Going down. Done? Hypovolemia, hypotension, hyponatremia, hypokalemia, hypocalcemia, but hyperuricemia, uric acid up. Hypersensitivity 1, uric acid second. Hypersensitivity 1 and uric acid second, the both common in thiazide and loop, common side effect. Okay. Ototoxicity, hypovolemia, hyponatremia, hypokalemia, hypocalcemia. Okay, understand? So these are the side effect of loop diuretics. These side effects be just because they're doing what? They're doing diuresis. Everything is going out, so that's why everything lost. Okay, that's why everything lost. The extra side effect, one thing keep in mind, hypersensitivity, they are ototoxic. They are ototoxic. They are ototoxic. Understand? Clear? About thiazide done. About the loop done. Thiazide is just not yet done. Uric acid high. If uric acid high, what doing uric acid? The uric acid, gouty arthritis, yeah, is also side effect of loop diuretics. Also side effect of thiazide. Understand? So if patient using loop diuretics for hypertension or heart failure, okay, if using, so this patient you must repeat serum electrolytes, must repeat, must check, check the sodium, check the potassium. Which side effect is very dangerous for heart? Which one? Hypokalemia is not a good thing. This one is very dangerous side effect for my heart. Understand? Clear or not? Till here done?
Yes, sir.
Yes, sir.
Third class done. Yeah. Okay. Now the last these two classes I will discuss in detail tomorrow, inshallah. I just let you know about a bit about thiazide. Thiazide. These are weak. Okay. These are weak because they just, you can see they just block 5% reabsorption. Yeah. Here you see. If you compare with loop, they act on this channel. They just block this sodium chloride transporter. So these are not much stronger. So for hypertension, now I ask one question here. For hypertension, which diuretic you start? Which one? Loop or thiazide? For example, one patient come to you for having hypertension. You want to start diuretics. It's your choice. You can start diuretics. You can start beta blocker. You can start alpha blocker. Anything. Okay. Which one you prefer for hypertension? First one. Thiazide or loop? It's a common sense question. Try to see what happened with nephron. 25% volume going out, just 5% volume going out. Which one you use first?
Thiazide, sir. Sorry, no. This one. Loop.
Listen. If you want to loop, listen carefully. If you want to loop, you must stay in hospital. What this meaning? Loop diuretics very strong. We use IV, okay, in severe condition. Thiazide just 5% water loss, yeah, just 5%. You can prescribe to any person, no problem, with no worry, yeah, just 5% water out to decrease your blood pressure without tension, yeah. So you can take thiazide drug and now you can stay at home, no problem. But if you take loop diuretics 25%, your volume going out, yeah, 25% is not a little thing. Understand? How about mannitol? You can use at home. Of course, never I'm use at home. Mannitol, menthol in hospital, loop diuretics in hospital, thiazide, very weak. Okay, thiazide very weak. Thiazide very weak. You can prescribe for hypertension. So for hypertension, if you want to use diuretics, you must start from thiazide. Okay, must start without doctor prescription, not go for loop. If the patient have like severe, for example, same case, heart failure, mild heart failure, not directly go for loop, okay, just go for thiazide enough, just go for thiazide is okay. If you like more volume there, then you can go for loop, because the loop a bit more stronger than the thiazide, yeah. Understand? The thiazide diuretics, hypersensitivity, yes. Uric acid high? Yes. Oh, these two common things. Another problem. Oh, thiazide diuretics. Problem with diabetes. Why problem with diabetes? Thiazide diuretics causing hyperglycemia. That's a problem now. So another issue with the thiazide. They cause hyperglycemia. They not allow insulin to work. They cause insulin resistance. Thiazide diuretics cause hyperglycemia. Thiazide diuretics cause hypokalemia. Thiazide diuretics cause hyponatremia. Thiazide diuretics cause hypomagnesemia. Thiazide diuretics cause hypercalcemia. Oh, this one is very important point to understand, calcium. Another one, this hyperglycemia point, very important point to understand, okay? Hyperglycemia. If the patient come to you having like diabetes plus hypertension, you want to treat hypertension. Now you use thiazide now? Of course not. Understand or not? Clear? You need to adjust the dose. You need to adjust the dose of insulin. You must change the time duration maybe. Better to not use thiazide. That's the best option. Why? Because thiazide diuretics not allow insulin to work. That's the problem. Thiazide diuretics make worse diabetes. Thiazide diuretics causing hyperglycemia. Thiazide diuretics cause hyperglycemia. Okay, understand? Okay, one benefit. Think about calcium. Hypercalcemia. One. Listen here carefully. An elder female, age 50 year. Listen carefully. Was hypertensive. Okay, which drug is very good for that lady? 50-year age, already menopause, no estrogen, have bone fracture, hypocalcemia, thiazide diuretics, very good for that lady. Why? Because thiazide diuretics give you benefit in osteoporosis. Thiazide diuretics help in osteoporosis. Understand? If any elder lady want to use antihypertensive, you must use thiazide. Elder lady, age 50 years, after 40. Understand? After menopause, because before menopause, estrogen there. Estrogen can save the bone. Okay. After menopause, what happen? No estrogen, osteoporosis start. Osteoporosis, that osteoporosis. For thiazide diuretics also used for osteoporosis because they save my calcium. Understand? They save my calcium. Hypertensive, elder lady prefer thiazide. Okay, these two are important concepts about thiazide. The potassium sparing are a bit more confusing. I will explain tomorrow. Okay, try to digest till these. Okay, see you tomorrow, inshallah.
Okay, sir. Thank you.
Yes. Assalamu alaikum. Allah Hafiz.
Waalaikumsalam.
Allah Hafiz.
Yeah.
Allah Hafiz.